So Jodie, what's your main reason for coming and seeing me today?
I have ongoing right gluteal and SIJ pain. I can't run, I want to run 5Ks and I can't so far because I pull up sore. And also we're considering starting a family maybe in the next 12 months, and I don't think my pelvis will get through 9 months of pregnancy.
So basically from today we want to explore if we think that there's things missing perhaps from your rehab.
Yep.
Perhaps like if I look at a pelvis, I'm looking at, so it seems to, I don't know yet, you may not have sacroiliac joint pain, it may be lumbar referred, but if I'm looking at someone with pelvic girdle pain, I'm often trying to work out, is it more lumbar driven? Is it just purely SIJ, which is not that common? Or is there perhaps some underlying issues of poor dynamic control of your hip on your pelvis that's making the loading strategies under, you know, when you're running, suboptimal through the sacroiliac joint? And also the fact that you've been, the main changer of your pain has been hip adduction strength. We're going to explore that a bit today. Then we're going to have a look at the ligaments around the SIJ, and I should be able to tell you from tonight whether or not I think you have what's called true ligament laxity or SIJ incompetence. So what that means is that when you activate muscles around the sacroiliac joint or the pelvis, and those muscles are sometimes lumbar driven, sometimes hip, you bind up through those deep ligaments of the pelvis, your interosseous ligament, your short dorsal, and what should happen is under that muscular load, you decrease your joint glide. Okay, a lot of people have some increased joint glide, and when they activate the muscles, they can get the stiffness, but they're just not doing it functionally.
Yeah, that's running. Me. I can do it in testing.
So if that's you, if you can stiffen up under testing, you're not a candidate for Prolo. I think you are tight anterior hip obturator, so then you're driven into a bit more anterioralisation of the innominants because of the tightness of iliacus. Then you're disengaging through posterior hip, giving you that sort of stability. But also the iliacus is a game changer for that intra-articular stability. If iliacus is taking the hemipelvis forward, it's hard to lock back into posterior rotation under load. So heel press and relax just to do some isometric facilitation. And then you're going to go into actual activation of the ER where you take it across the other leg. Now I'm a big one for doing, you can do small ones, you can do larger range, mix it up, mix up the speed, mix up the range, control on the way back. So you might not be ready for quicker ones.
Yeah.
I need you with more control.
What do you think would the contributing factors in her history as far as maybe why this came about? Or
it seemed to have started off more with a flexion-based incidents where she started with lower back pain and radiculopathy. That settled, but perhaps that altered neuromuscular control around the lumbar pelvic region where she started to load up poorly into that right sacroiliac joint. The sacroiliac joint, the ligaments or the posterior ligaments, if you keep hanging back or if you fatigue and you're not locking into that posterior rotation, you're going to get ligaments, you know, you're going to get creep, you're going to get pain, and then as soon as you start to stir up sort of pain, well then that's going to alter neuromuscular control. So it's all just feeding into one another. It's not an incident of trauma, often around the sacroiliac joint it can be, that they land heavily on one side or land on their butt. That doesn't seem to be the case. And that's probably too why she can have episodes where she's got quite good control and others when she doesn't.